Thank you, Stuart. I'm very pleased to be here today just to give you a brief update on the guidelines for the detection and management of chronic kidney disease, which have been released in the last 12 months. So firstly, what is chronic kidney disease, or CKD as we abbreviate it? Well, there are three major components to the definition of CKD: structural, functional and temporal. So CKD is defined as the GFR that is below 60 mL per minute for at least 3 months, and or evidence of kidney damage such as albuminuria or hematuria, pathological abnormalities such as a renal biopsy, or anatomical abnormalities on an ultrasound. So the question now is, why do we need to bother about CKD, and how does it impact on patient management? Well, CKD is common, it's harmful, but it's also treatable. Firstly, you need to be aware that CKD is largely asymptomatic, so people can lose up to 90% of their kidney function before they notice any symptoms. The Beach study showed that 11% of adults who visit a GP have some form of CKD, but the vast majority are unaware of it. If you have CKD, you are at highest risk of developing cardiovascular disease. You are up to 3 times more likely than age and sex-matched populations to develop cardiovascular disease. And also, if you have CKD, you are 20 times more likely to die in the community, usually from cardiovascular disease, than to require dialysis or transplantation. This figure represents what we call the iceberg model of kidney disease. When talking about kidney disease, most people focus on the stages up here, the advanced stages, the 19,000 people that are currently on dialysis or transplantation to stay alive. But the vast majority of CKD that you will see in your general practice are here, in the stages 1 to 3, who are usually without symptoms and mostly unaware that they even have CKD. As well, we know that 1 in 3 Australian adults is at increased risk of developing CKD due to the presence of risk factors such as hypertension and diabetes. So that's a brief prelude about the epidemiology of CKD, but now we're going to focus on 4 key developments that have occurred in the last 12 to 18 months. There's a new staging scheme for CKD, new blood pressure targets, and new recommendations for how to detect CKD using urine protein and eGFR. These changes are all summarised in the latest edition of CKD Management in General Practice, this red book here, which was published in March 2012. And at the end, I'll update you on how you can get your copy of the booklet. So first, looking at the recommendations for how to detect CKD, we utilise a 3-step approach, what we call a kidney health check. It's a blood test to estimate the GFR, a urine test for albumin, and a blood pressure test. Now, it's been shown that it's not cost effective to test the entire adult population for CKD, but it is effective to routinely assess people who have 1 or more of the CKD risk factors. So this table outlines those risk factors. You can see down the left-hand side, we have smoking, diabetes, hypertension, obesity, established cardiovascular disease, which is a previous history of smoke or heart attack or heart failure, family history of kidney disease, and being of Aboriginal or Torres Strait Islander origin. And you can see from this table that if you have 1 or more of those risk factors, then it's recommended that you have a kidney health check at least every 2 years, or every year if you have diabetes or hypertension. So I'm now going to talk a bit more about the guidelines for the detection of CKD in more detail. Early detection of CKD is critical, as detection and best practice management can reduce the progression of kidney disease and cardiovascular risk by up to 50%. And control of symptoms once they appear can also dramatically improve quality of life. The CKD guidelines support the use of GFR as the best measure of kidney function. A measured GFR is quite difficult to perform, but GFR can be estimated, and we call this the eGFR. This uses a formula based on creatinine, age and gender. And since 2005, it has been recommended that pathology laboratories routinely estimate GFR every time a serum creatinine is ordered in an adult. And we now believe that almost 100% of pathology laboratories do this. A normal GFR should be over 90 mL per minute, and GFR of less than 60 mL per minute for more than 3 months indicates CKD. When looking at your eGFR, it is important to be aware of situations when an eGFR may be unreliable or misleading, and this is mainly due to the creatinine component. The CKD guidelines also deal with other important issues regarding the use of eGFR. Firstly, it is known that eGFR decreases with age, and some degree of reduction below 60 mL per minute in elderly people has previously been regarded as age appropriate or normal. However, we now know that eGFR less than 60 mL per minute is associated with increased risk of adverse renal, cardiovascular and other clinical outcomes irrespective of age. So eGFRs less than 60 always require further investigation. There's also a lot of work being done validating the eGFR equations in different ethnic populations, particularly a large study looking at Aboriginal and Torres Strait Islander peoples. And this work has at this stage supported the use of this equation in these populations. The validity of eGFR equations has not been proven in pregnant women. The validity studies have not been done. So serum creatinine remains the preferred test of kidney function in these populations. And finally, using eGFR for drug dosing has been a controversial issue. Most drug product information has been prepared using creatinine clearance. It is now agreed that eGFR can be used for drug dosing in people with kidney disease, but for very large or very small people, it may be preferable to use an eGFR that has not been corrected for body surface area. And again, that's based on the creatinine component of the formula. Now I'm going to talk about the guidelines for the recommendations regarding urine testing. Previously, a protein dipstick was the usual way to detect excess protein in the urine. It is now recommended that a urine albumin to creatinine ratio, or ACR, is the best way to detect CKD. ACRs are regarded as more sensitive and specific than protein dipsticks, and they are accurately been shown to predict the progression of CKD. While random spot specimens are okay, particularly for the first test, it is preferred that follow-up tests are performed on the first void sample. It's also important that repeat ACRs are performed, as there are a number of factors that can affect albumin excretion, as shown here on this slide. The CKD guidelines also touch upon blood pressure because of the intricate relationship between kidney disease and cardiovascular disease. We present new guides for blood pressure in people with CKD. It is now recommended that for people with CKD, blood pressure should be maintained consistently below 140/90. And this is higher than previously recommended, as research has been unable to demonstrate cardiovascular benefit of having tighter targets. However, it is vitally important that lifestyle intervention and medication is used to ensure that blood pressure remains consistently below these levels. Finally, I'd like to focus on the new scheme for the staging of CKD. This has changed significantly in the new guidelines. Traditionally, CKD staging was based only on eGFR results. The new evidence emerged to show that albuminuria is just as important as eGFR, and combining the two indices results in improved quantification of risk for CKD progression and cardiovascular events. So this is the new CKD staging schema. It incorporates the old staging system of GFR stages 1 to 5, however that's where the similarities end. You can see from this table that CKD stage 3 has been divided into 3A and 3B. Now, approximately 60% of the CKD patients that you will see in general practice will be in stage 3. It has been shown that the risk of cardiovascular disease and progression of kidney disease is significantly greater once the GFR falls below 45 mils per minute. So that is why stage 3 has now been divided at that point. On the horizontal axis, we now also incorporate measurements of albuminuria, which we divide up into normal, microalbuminuria and macroalbuminuria using the gender-specific cut points you can see on the table. Now, the reason for having gender-specific cut points is that women generally have less muscle mass and therefore a lower degree of creatinine excretion, which impacts on the ACR results. Once you do the stratifications for GFR and albuminuria, you refer to the table, and where the lines intersect gives you an idea of the individual's level of risk. You can see that the table cells are colour-coded, so that green equals low risk, yellow is mild, orange is moderate, and red is high. And to accurately stage CKD, you need to know the eGFR, the albuminuria status, and the underlying cause of CKD. So you would say, for example, Mrs. X has stage 3B CKD with microalbuminuria secondary to diabetic kidney disease. Bit of a mouthful. The colour-coded cells are then used to relate to colour-coded clinical action plans, which are included in the guidelines booklet. The 3 clinical action plans detail relevant goals of management, monitoring timeframes, and clinical and laboratory assessments depending on the stage of CKD. The clinical action plans focus on these 7 principal goals of CKD management: management of the underlying cause, self-management, reduction of cardiovascular and kidney risk, early detection and management of CKD complications, avoiding nephrotoxic medications and modifying drug dosages, and timely referral to a nephrologist. Now, most of the early stages of CKD can and should be managed in primary care, but it is also necessary to know when referral to a nephrologist is indicated. This slide outlines the 5 major criteria for referral based on a low eGFR, persistent significant albuminuria, consistent decline in eGFR, hematuria, or CKD and hypertension that is hard to get to target despite at least 3 drugs. As always, though, you need to base these referrals on individual people, and sometimes for younger people more stringent criteria will apply. So to summarise this very brief update of the CKD management guidelines, CKD is common, it's harmful, but it's treatable. Opportunistic testing for CKD using the kidney health check should be performed every 1 to 2 years in people with 1 or more of the risk factors for CKD. CKD staging now requires knowledge of eGFR and urine ACR. And lastly, don't ignore the low eGFRs in the elderly patients. Thank you.